Good morning, everyone. Happy Monday. Thank you for tuning in and joining us for our virtual programming here at the Denver Museum of Nature and Science at home and the Institute for Science and Policy. I'm Kristen Eulenbrock. I am the Senior Policy Advisor at the Institute for Science and Policy and your moderator for this COVID-19 webinar series that we've been hosting. Just a little housekeeping here right out of the gate. I want to let everyone know that we're going to be taking a break next week for Labor Day as to be expected, but we will be coming back on September 14th where we'll be hosting vaccines and herd immunity episode. So please remember to not tune in next Monday, but to come back on September 14th. We're really excited for everyone who's been tuning in today. See a lot of familiar faces as well as some new folks. So I just want to remind you that this is really meant to be an audience-driven Q&A as we get to the latter half of the program. So we want to hear your questions. If you're in Zoom, you can open that chat feature and type your questions in right there. We've got eyes on those and we'll incorporate some of those as we get towards the end. If you're tuning in on Facebook Live, hello to you on that platform as well. And feel free to use that comment feature for your questions that you have for our speakers today. Today is episode number 17. So yes, we have hosted 17 of these webinars so far. That means there's been a huge amount of people who've joined us as far as their expertise and speakers. We've rarely had one speaker for any one of these episodes. So we've had a lot of tremendous folks join us and I'm super thankful for all of their time and dedication. A huge thank you to our partners, the Colorado School of Public Health. And for those of you who know, we're in for a treat today. We have Dr. John Samet, who is the Dean of the School of Public Health, joining us again today. They've been really great thought partners in this series all along. And a huge thank you to all my museum colleagues and to you, our audience. You've been a really engaged and thoughtful audience. And we're hoping to make this series very timely as we continue on. So we always want to hear the ideas that you have for topics. So on to today's episode. Today's episode is about the airborne nature of the coronavirus. Scientists and researchers are still trying to figure out the extent of the transmission of SARS-CoV-2. What is the size and range of the particles and how long do they linger in the air? And for how far might they travel, particularly in enclosed and indoor settings? This science is evolving right in front of our eyes. And so what I also think is fascinating about this virus in particular is some of the cross-disciplinary collaborations that have come out in trying to understand what it is doing. And so we're in a treat today because we're going to be hearing from John, who's going to be sharing literally what came out of a workshop just last week from the National Academies. And I was looking at the lineup for that workshop and it was extremely interdisciplinary in scope. And also joining us is going to be one of the speakers from that two-day National Academies workshop, Shelley Miller, who comes with her experience about the built environment. So let me introduce our two wonderful accomplished researchers today and turn this over to them. First, as I have already mentioned, is our dear friend and partner, the Dean of the Colorado School of Public Health, Dr. John Samet. Dr. Samet is a pulmonary physician and epidemiologist and serves as a professor within the school's Department of Epidemiology and the Department of Environmental and Occupational Health. He's been spearheading our modeling efforts here in the state of Colorado, and is going to give us an overview of the epidemiological perspective about the virus particle size and some of the discussions from last week's National Academies meeting. We also have Dr. Shelley Miller with us today. Dr. Miller is a professor of mechanical engineering at the University of Colorado Boulder and faculty in the environmental engineering program. Her research interests include indoor air quality, urban air pollution, health effects, and the development of indoor air quality control measures. She's taken her extensive career in air quality and applied this to her understanding of how to prevent the spread of COVID-19 indoors, as well as sharing with us this morning a little bit about this research and the ways we can potentially mitigate the spread. So with that, we're going to turn this over to our first speaker and presentation this morning from Dr. John Samet. Good morning, John. How are you?
Good morning, Kristen, and it certainly appears that fall has arrived. I also note that we have someone listening from central Sweden, so that is a long reach for the series. So what I'm going to talk about are important issues that have come up since the pandemic began about transmission. And I'm going to be speaking specifically about the findings of a workshop that was held last week. And Dr. Shelley Miller was one of our speakers. This has been an incredibly controversial topic because of the implications. the mode of transmission speaks to the mode of control. And I'll give you the historical example of tuberculosis in just a moment. Small particles that travel lead to quite different strategies in thinking about control than large droplets that are sprayed and perhaps have only immediate contact with people within that magic distance of 6 feet. So this has been an important topic, and a lot of good research has been done. I'm going to go back to the historical example of tuberculosis. Tuberculosis control was once about not spitting into spittoons, not spitting on the sidewalk. And in fact, the original version of the American Lung Association, its control measures were about not spitting. In the mid-1950s, very convincing experiments showed that tuberculosis was transmitted through the air. Think about the paradigm shift and the move to control airborne transmission and not spitting. So a shift in control strategies because of the way what we learned from research. So when we come then to think about SARS-CoV-2, there's a number of different ways that it could be transmitted. So one is direct contact between people, touching the hand of someone who has touched their face and now has SARS-CoV-2 on their hand. Indirect contact through objects and surfaces, so-called fomite transmission. I don't know why we don't just call it surface contact, but fomites is the word used. Larger droplets sprayed directly. Think about somebody coughing or sneezing next to you. And then these smaller particles, which have been referred to as aerosols. Perhaps all are important, perhaps some are more important under certain circumstances, but clearly there are important implications for control. So I'm going to talk about a workshop held last week by the National Academies of Science, Engineering, and Medicine. I chaired the planning committee for the workshop, which was carried out by a special initiative at the National Academies, the Environmental Health Matters Initiative. The National Academies was designed just for this kind of controversial question. It was chartered while Abraham Lincoln was president to give guidance, science-based guidance, to the government. The original National Academy of Sciences has now been augmented by the National Academy of Engineering and the National Academy of Medicine. And this organization, with its Special Environmental Health Matters Initiative, put together this workshop that brought together, I think, leading experts from around the world on the topic. This is how we thought about the problem. People are the source over on the left, and in the end, causing the infection and the disease COVID-19 is the deposition of virus particles, so-called virions, into the respiratory tract, the nose, the upper airway, or the lung. Some dose gets there. And we took a look at the steps along the way. People are the source of particles, they generate them. How do people generate those particles? What's important about the activities that generate them? What is present in the air? Is there a live virus? Can samples be collected and then the virus cultured? Once the virus is in the air, what determines how much we're exposed to? The way buildings operated, the topic that Shelley will address, important. And then this important question about what gets into the lung. And does it matter how much gets into the lung? Then, of course, overlaying this whole people to dose framework are these contextual factors. Who we are, what are the homes like where we live, the environment, medical care, income, which drives our access to healthcare, the quality of housing. And so many of these contextual factors have unfortunately set up for the inequities that we've observed with the pandemic and talked about in this series. So let me give you some conclusions. There's an awful lot here, and I will tell you that the proceedings of the workshop eventually will be out, a brief summary, but the actual talks will be posted along with the presentation materials at the Environmental Health Matters Initiative piece of the National Academy's website. So that should be available soon. So, to just right from the start, people generate infectious particles. And as Dr. Miller will show you, we produce lots of particles during our regular activities. The droplets are the larger one. They travel a short distance, and they have a short residence time in air. The aerosols are the smaller ones. They travel longer distances. In an indoor space, they may mix throughout the space, and they can stay in the air for hours. And over those hours, some may remain with viable virus. We generate plumes. The louder we speak, the more particles we generate. Singing and wind instruments are risky. It's sort of a setup for why bars have possibly been a dangerous or risky locale, because they often have music playing in the background. People have to talk loudly. They're taking their masks off to drink. And perhaps alcohol, leads to a lack of inhibition and a failure to adhere to distance, social distancing. So, just as an example of why this is important and what locations may be risky, here is one explanation for why bars may have been particularly dangerous. Now, aerosols, the smaller particles, are important. And one thing that came out of the workshop was a good discussion about terminology and definitions. And I think some very helpful suggestions about harmonizing terminology will be coming. But think about the aerosols as the smaller particles. They travel beyond 6 feet, and this makes them really important in indoor environments. Perhaps less so outdoors where the wind may be blowing and there's dilution, but indoors they can remain airborne for hours. And as I said, the virus can remain viable. So this is really critical as we think about how to manage buildings. Dr. Miller is going to talk about behavior and buildings, and I leave that to her. Now, just an important conclusion, we still don't really know enough about the amount of virus inhaled into the lung, what risk for disease looks like, or what the disease itself looks like. If we inhale more virus, for example, is the picture clinically more severe? So this is an area where there's some animal work that is very interesting and gives us some insights, but for people, we still lack information. It's very hard to come by because obviously we can't directly challenge people with different amounts of virus to see what happens. In fact, some such experiments have done in the past with more benign viruses, but certainly not for this one. But animal models are informative here and giving us some insights. Now, I think one message that came out for me was that we need a package to deal with airborne transmission and not pieces. And I'm going to show you some slides that I borrowed from Lindsay Marr at Virginia Tech, one of our speakers and an important voice on this problem. So I'm just going to run through different interventions. So source control, remember, we're the source. And here is somebody with the immediate large droplets. And then you can see the little small red particles in the air, the aerosols. And notice that on the floor, there's virus. And one thing that came out of the workshop was that much of what is in the air, indoors in particular, is resuspended dust. And that resuspended dust or particles can contain virus. So important then is keeping surfaces clean, including floors. So here we are, mask source control, okay? And that is, we wear masks to protect others. And as we learned in the workshop, we also learn wear masks to protect ourselves. Ventilation and filtration will be discussed by Dr. Miller. Again, trying to reduce exposure to people once the virus is in the air. And there's a HVAC unit up there in the corner. And then distance and personal protective equipment. So again, that 6-foot distance helps us with these larger particles, the droplets. People talk about spray transmission, and I think anybody who's been within range of somebody coughing or sneezing knows exactly what we're talking about when we talk about spray transmission. And then personal protective equipment. So masks help with not projecting virus into a room, into a space, but they also provide protection for the wearers. And then, of course, hand hygiene, keeping surfaces clean, and all else are also critical. So in the end, what we need are all four modalities. And that's why we need not just one piece, but we need to keep doing everything while the pandemic lives on. One of our participants on a panel, Bill Nazaroff from Berkeley, worked on air quality for a long time, summarized with this. He gave a poetic reading, but I'll just read it to you. And outdoors is better than indoors, of course, because there's dilution. Short time, potential exposure better than long. Masked, better, let's say far better than unmasked. Socially distant is better than too close. Sparse number of people, better than crowded because we are the source. Quiet is better than loud because we project more as we speak louder. Gentle breathing better than vigorous breathing. Risk can be lowered indoors, but not eliminated by improved ventilation and air filtration. So, and that is the topic that Shelley is going to take on now. So with that, let me turn things to Dr. Miller. Thanks so much.
Great. Thank you, John, very much. We're going to come back because we've got some questions already specific to you, but let's get Shelley involved in this conversation. Good morning, Shelley. How are you doing?
Good morning. I'm great. Hey, thanks for having me here. It's a real treat. I've been watching them on my own as well, so it's nice to join the audience and speak with you. I am not speaking from the University of Colorado Boulder, but from my home office. But I thought we would take a gander at the campus today with my background. So let me go ahead and share my screen, and I will present to you what I talked about at the National Academies workshop, which was just an incredible experience to be a part of. And I'm really happy to be able to inform the question here, which is what I talked about was the role the built environment plays in determining exposure. First, I want to alert you to the fact that I have written these 2 articles that are useful for community and the public to try to understand the issues at play. The first one was in April on what is the science of infectious aerosols, and the fancy picture of the cough, and the one on the left was then last month about how to use ventilation and air filtration to prevent the spread indoors. So you might want to read those if you haven't. This graphic was one that we developed for a paper we wrote on how to minimize transmission indoors. And the things that I want to alert you to are 3 things I want to talk about today: ventilation, air cleaners, and UV lamps or air disinfection. Let's go ahead and start with ventilation. The big question on the table for actually decades has been what ventilation rate is needed when you have an infectious disease outbreak. A study coming out of the University of Maryland looked at acute respiratory infections that are often heavily transmitted during the winter months through dorms at college campuses. Here they studied in great detail the ventilation of 2 different dorms. One was a high ventilation dorm and one was a low ventilation rate dorm. They measured the dorm rates, ventilation rates, as 6 liters per second per person, which is how we usually describe ventilation. We provide outside air at a rate per person in the indoor environment. The low ventilation dorm was only 2 liters per second per person. And the outcome was that only 1 out of 11 residents got an infection over the winter months, whereas in the low ventilation dorm, 47 over 109 got infections. And we've seen this kind of data over the last decades in multiple locations. So a literature review by a colleague out of Denmark showed us that outdoor air supply less than 25 liters per second per person increases the risk of sick building symptoms, short leave from sickness, and decreased productivity. So if we can bound our ventilation rate that's needed in an indoor environment between 5 liters per second per person and 25 liters per second per person, somewhere in there is the right ventilation rate for most spaces, depending on the use. I also want to alert you to this study, which I just find fascinating. They had a tuberculosis outbreak, which we know is transmitted by aerosol, in a university setting. And what they looked at was the ventilation rates of these buildings where the outbreak happened. The outbreak started on November 10 with the index case, and the subsequent cases followed. The ventilation rate in these buildings was 1.7 liters per second per person, very low. So they did a bunch of engineering to increase the ventilation rate, and they got it up to 24 liters per second per person. And showing that after that engineering in the system to increase the ventilation, the outbreak stopped. We also see that the carbon dioxide was a good indicator of ventilation. So when you don't have enough ventilation, your CO2 accumulates indoors, and it average was 1,200 and it maxed out at 3,000. Whereas when you increase the ventilation, you got it down below 600. I also want to explain air change rates. A lot of this has been talked about in the media and also in articles, such as the one I wrote. An air change rate is a normalized value of ventilation. It measures the outside air volume added to the space, and you normalize it by the volume of that space. So let's take an example of a 500-foot classroom. The American Society for Heating, Refrigerating, and Air Conditioning Engineers, quite a mouthful, recommends 6.7 liters per second per person of outside air in a classroom. Their typical occupancy is 35 students per 100 square meter. So if we put this ventilation rate into a classroom with 35 students, and the square area of our 500-foot classroom is now in square meters, we provide 109 liters per second of ventilation, outside air, into this classroom. The air change rate is determined by dividing by the volume of the space, and then I change the units of time so that we get 3.5 air changes per hour. The time for much of the room air to be exchanged with the outside air is 17 minutes, whereas the time for all the room, so every bit of air in that room that was in it is now put outside and fresh air is brought inside, and that takes 51 minutes under a 3.5 air change per hour scenario. But please note, this air change rate varies a lot during the day, even from the morning to the night, because of the temperature differences from the number of people inside, what they're doing, and from one environment to the next. One of the key reasons that we know aerosols are transmitting this virus is because of the outbreaks. We've had numerous outbreak reports that can only be explained by aerosols and not by anything else. For example, in this restaurant where we had one pre-symptomatic person in the yellow here at table A, came into the restaurant to eat lunch at this Chinese restaurant in Guangzhou. And as a result of this episode, we see infections at tables A, B, and C. Why did this happen? Because there was no outside air supply, and the aerosol was not diluted in concentration, and it just built up over time. And these strong air currents from the air conditioner blew the virus across all three of these tables. An additional outbreak that I've studied extensively was the Skagit Valley choral rehearsal outbreak, where we had half of the choral come to practice for 2.5 hours, and 87% of the attendees were infected and started having symptoms the very next day from COVID-19. So in our study, we estimated the average, what we call quanta emission rate. This is the amount of aerosol that it took to get people sick. And then we wanted to explore how we could have prevented this by maybe adding more ventilation. So these figures come from our table, and I'm going to explain them briefly. The one on the left is the probability of infection versus the loss rate coefficient, which includes the ventilation rate, any surface deposition that does happen, and then whether the virus was inactivating while it was being airborne. And the dark black line is our estimate of the infectious dose response for this particular outbreak. It was 970 quanta per hour that was emitted, and we estimate that their ventilation rate in this space was probably less than 1 air change. So we have a probability of infection of 87%. It would take a lot of ventilation, all the way up to 12 air changes per hour, to even get this infection rate down to 20%. So what we did was look at the duration of the event, which is now the graph on the right. And what we see is that the solid line is the 2.5 hour rehearsal. And the lowest dash line is only a 30-minute rehearsal. And we can see immediately that even with 1 air change per hour, if you don't spend too much time in that space where there's infectious aerosol, your probability of infection goes from 87% to just 10%. And so this is one of the reasons why I've been recommending quite often to not spend more than 30 minutes of time in a heavily occupied space, such as a classroom, where there's might be aerosols being emitted. Let's talk about filtration. I want to alert you to some really great resources. You can read the EPA Guide to Air Cleaners in the Home. It's very well done. It's out just 2 years ago. And the California Air Resources Board provides really good information as well on air cleaners, and also recommends do not buy ozone generating products. The way a filter works is that it basically puts the air that has been contaminated and draws it through a fiber filter. Kind of looks just like your furnace filter, but a lot more finely woven. And then the clean air is on the other side. This is the minimum efficiency reporting value, and the dip in the efficiency of the filter curve always happens at 0.3 microns. And then it goes up from there to the left and up from there to the right, meaning it's very efficient at removing very small particles and very big particles. And we know that the COVID-2 virus is less than 0.10 microns. And so anything above 0.2 to 1 to 10 microns and higher is very efficiently removed. The rating numbers is just how good the filter is. And right now we're recommending for recirculating HVAC systems to use 13 or higher if they can. And the high efficiency particulate air filter, which you've heard possibly a lot about, is the HEPA filter. That is 0.997% efficient at removing particles at 0.3 microns, meaning it's very efficient. How do you know what air cleaner to buy? Well, what you want to look at is the clean air delivery rate. On the right is a certification seal from the Association of Home Appliance Manufacturers. And this certification tells you that this particular air cleaner can work in a 120 square foot room, and it will remove 80% of the dust in the room, 80% of the tobacco smoke, and 80% of the pollen, which is gonna work for coronavirus. And so how would you, so I wanted to show you some data from my lab that shows these things work. On this graph is the clean air delivery rate for bioaerosol. So that's the material in the air that has microorganisms in it. And what we find in this study is that air cleaners work for a variety of different organisms just the same. So if we're trying to remove a mycobacteria, which is what gives you TB, and that's about 1 micron, it works just the same as if you're trying to remove a fungi aerosol, which could also cause allergies and asthma. And right in the middle of there would be the SARS-CoV virus as well. It could remove it just the same. What you see on the 2 different graphs is that Air Cleaner 1 has a higher clean air delivery rate than Air Cleaner 2. And what does that mean? Well, that means you can only use Air Cleaner 1 in a 30 cubic meter room, and you can use Air Cleaner 2 in a 4 meter room. So making sure you get the right clean air delivery rate. My last topic is germicidal ultraviolet UV, and then I'm going to talk a little bit about musician aerosols. What I have, and I'll just briefly say that I've been studying germicidal UV for over 20 years. It damages the DNA of microorganisms, and they can no longer replicate and cause infection. The wavelength at which that happens is 254, and 260 is where the infectivity is the highest. So if you can inactivate them, there will be really efficient. We really only recommend that they are used in places that can be maintained, designed, and operated effectively, because what you do is you hang the UV lights in the upper zone. It irradiates just the upper zone. The lower zone where people are is not irradiated because it can cause skin and eye irritation with overexposure. So here's some environments that I recommend considering where you would use them in. For example, rooms in which you don't have enough outside air ventilation, but you need to add additional air changes, or in crowded environments where unsuspected infectious persons may be present. Some data on the upper right shows that as you increase the effective UV irradiance on the x-axis from, say, 1 microwatts per centimeter squared all the way up to 6, you can increase your air exchange rate that you're adding with this UV. We got 17 air changes per hour in our study. Our study data has been published in the CDC guideline for healthcare settings on how to use germicidal UV. And we found among different, well, we didn't, this study did, and I find this to be a really poignant point, that among different engineering control measures, UV singly was the optimal strategy combined with effective isolation and vaccination for containing influenza, measles, and chickenpox, which seems like the kind of situation we're in right now. I want to conclude in my last minute with some data that's coming out of my lab now on musicians. We're studying aerosol emissions because we think wind instruments as well as singing generates a lot of aerosol. So here we have an oboe playing into our particle measuring system. It counts the number of particles that come right out of the bell. And so what we had the oboe player do was play right near the inlet of our aerosol sampling instrument. And we see that when they play near the bell, play a scale or just play in general, you get a lot of aerosol being emitted. But if we put a bell cover onto the bell, it really reduces the particle emission so that it's just almost the same as background or even reading. Singing is similar. We did find more aerosol released with oboe. And I want to conclude with just a short video here. I'm at 14 minutes, and so I'm just going to take 30 seconds here to share this screen so that you can just see a little bit of what we have been doing, because the first thing we do is try to figure out where the flow is, and then we sample that flow. This is our clarinet, and I'll just do this in the singer. So here's the disturbance and the flows right here, and you can see with the disturbance and the flows, we might see aerosol. And then I'll just go to the singing one. That's at 3 minutes, and this video is available. I had to play the chorus for you. That's always my favorite. She is a singer at CU Boulder, one of our graduate students. So I'm going to conclude there, and I'm happy to answer any questions. I'm right at 15 minutes. Thanks for having me.
Thank you, Shelley. We have so many questions coming in. We are not going to get to all of them, but I'm going to try to give you all some to start. I'm going to start a little high level. Let me start with Shelley, and then John, you can add on too, because I'm going to make this a two-parter. So you had showed 17 minutes and 51 minutes scenarios for the air exchange in the classroom. I mean, is there a rule of thumb or something that people can kind of take away from that from themselves? They're curious about their home office buildings and other places. How should they be thinking about time spent in a room? And is there any sort of rule of thumb that we can give folks, knowing there's so much different ventilation and air things? And then, of course, let's layer on this, and John can pick up from you about wearing a mask in these rooms and the additional filtration potentially that is designed within masks. So Shelley, do you want to start about timing and maybe on mask, and then turn to John?
Yeah, sure. I know. I think as a member of the public, it's really hard to walk into a space and know anything about the ventilation. And so what I recommend is first making sure there's not a lot of people in there, that everyone's wearing masks, which John will talk to. But then also if the room feels stuffy and hot, then it's probably not having enough ventilation. If there's no windows open or nor doors open, it's also probably doesn't have enough ventilation. And other than that, I mean, there's really nothing else you can do unless you want to get a little high tech and take a carbon dioxide detector with you and make sure the carbon dioxide levels are below about 600 to 800 parts per million in an occupied space. If you have to go there often as a worker, that might be a good tool for you to use. Or you need to ask the facility managers, you know, what is the ventilation rate? Are you following ASHRAE guidelines? And if they are, then that should be, you know, an adequate amount of ventilation, especially if the space is not occupied as much as it usually is.
So maybe just to add on, I mean, of course, we don't walk around with little devices that tell us how many viruses are in the air. If we did, perhaps it would be problem solved and we can go into a contaminated space and leave. But I think this is where wearing masks help, because for those who are in the room, wearing masks reduces the loading of the room with viruses and provides protection. So I think the mask orders remain quite relevant to public health protection.
Let's move into people's homes even a little bit more. So someone asked about specifically their swamp cooler, right? And is there any data or evidence that the airborne COVID could be brought in through their swamp cooler? And then building on with that, I think people have been concerned because of the wildfire smoke and how they've been filtering their home and turning some of this off. Is there any evidence that like larger particulates like smoke and everything could be carrying that virus further? Shelley, do you want to start with us?
So swamp coolers, yeah, I don't have any, we don't have any information about how that's going to particularly impact the flow of a virus in an indoor environment. I think still we want to go back to basic principles, which is, you know, making sure you have enough outside air. A swamp cooler does need outside air to work. And so that's good. And I think that is a good thing compared to if you have your room really closed up and you're just running one of those mini split air cleaners.
And I think maybe I'll add, maybe Shelley, please jump in. The question of sort of, you know, the usual particles that are present in the air, sort of carriers for virus. I think that's probably an unresolved issue at this point. There's been discussion about it, that perhaps viruses tag on, particles do, the technical term agglomerated as they come together and hit. So perhaps there's a carrier role. The smoke particles that reach us from wildfires up to, you know, really several hundred miles away or thousands of miles away from California are going to be very small by the time they get here. We know they're here because we smell them, and the nose is a great detector. And clearly, you know, for example, swamp cooler that brings in outdoor air will bring in whatever is in that air, including small smoke particles. But putting the story together, those particles could somehow increase the risks of SARS-CoV-2 becoming infected. I don't think we have enough information to say that.
If I could just add about the resuspension issue, you know, the particles eventually will settle onto surfaces. And there has been data that shows that when you sample the floor and different areas of places where there's lots of contamination, you find a lot of virus. And there is implications of resuspension or virus being shed when hospital workers take off their gowns and their PPE. And so, you know, definitely understanding that if you're in a high contamination environment, you could resuspend those particles, and you want to be careful. I used to just have COVID shoes that I would only go out in and just make sure that in case walking around you picked up some, you just leave it outside of your house. I don't worry so much about that anymore, but.
Yeah, thank you. That actually tied into someone else's question about surfaces being clean, you know what I mean, and that resuspension. So I think you touched on that a little bit. People are really interested in, should there be additional things that they buy, such as an additional air filter, or is their kind of high efficiency heating and cooling system enough?
For homes,
Yeah.
if we talk about homes versus classrooms, it's a different issue. I recommend people have air cleaners if they're sensitive. They're sensitive, asthma, or they have possible COPD, especially in summer with wildfires. So it's a really great tool to keep your indoor environment clean from particles that can make you sick. Now, whether it's going to help you in your home, I would say you don't have a lot of potential for transmission unless you have a lot of people in your home that may be going in and out and going to work, and that you're worried about them coming back and having been contaminated. So it just depends on what your concern is.
And speaking of businesses then, right, we are potentially moving into some cooler months more. People are going to want to try to congregate indoors more. There's going to be a lot of, tough decisions to be made about number of capacity of people in room. Are there recommendations that businesses should be thinking about now as we think about coming into the winter colder months that they should be taking if they haven't already?
Well, I did say this at the National Academy, so say it now, just in case someone is listening and they can work on this problem, which is that I would like to see business have the ability to share with the public what they have done to improve their outdoor air ventilation and air cleaning. So for example, having even, some inspection service that comes and says, for the city, that says, okay, you have 3 air changes per hour in this room, and so you get a certification. And then the restaurant says, and I've also added an air cleaner that gives me another 3 air changes per hour, so that you as a patron will know what they've been really trying to do to keep you safe in their space. It's very difficult for patrons and for businesses who are maybe even just renting spaces to express how the air is going to be safe in their environment without a little bit of support around that, I think.
Just a few comments here. Fall is usually the time when respiratory infections surge, and that's because we go back indoors, and of course children return to school, and they're very often the introducers of viruses into the home. Colorado's epidemic right now is in a good place, fortunately, as we head into the fall and the school reopenings, and of course it's going on a very varying way across school systems. So I think we need to continue taking steps with all the measures that we have. We're concerned, for example, that Labor Day is a time when people will be together. There may be social gatherings. We saw a surge after the July 4th weekend. We hope that won't happen because it would come coincident with, it getting cold like this morning and going back indoors. So we're at a tricky time. And I think totally agree with Shelley. This is a moment we want to make sure we're doing all that we can, including how our buildings are operated, to keep the population of Colorado as safe as possible.
John, could you speak a little bit more to viral load and exposure, and what's our current latest understanding on that?
Yeah, I guess the answer, Kristen, is I wish I could. I think one thing I learned from the workshop, and I think it's a little bit out of my sort of own research territory, is that we have animal models that we use to look at viral load, and as such, they're not people, but they are helpful. But I think fundamental questions about, and this goes back to, for example, Shelley's discussion of quantum, how many of those have to get into the lung, or where they travel into the lung? Do they get into the deep lung, or are they pulled out in the nose, which is a filter? It's just not clear. And I think it will be useful to answer those questions, particularly as we, move into winter and need to make sure our indoor environments are as low risk as possible.
Mm-hmm. Shelley, I wonder if you could speak to a little bit about the use of filters in UV when it comes to not killing beneficial microorganisms, and how sometimes this person's interested in the killing of biodiversity as creating that opportunity for other pathogens to take forward. Could you speak to that interconnectedness?
So unfortunately, we don't actually know which microbes in the indoor spaces are beneficial. We have been studying what the microbiome looks like in your home. And the bacteria in your home come from who's in your home, your people and your dogs. The fungi in your home come from where you live, from outside your home and into your home. And same with businesses. Now, which ones are good for your health and what makes you feel better and what's good probiotics and all that, remains to be discovered. We know what the pathogens are, and we know that, for example, in really different environments like healthcare settings, there is this tendency for a pathogen to overtake because of the high levels of disinfection and contamination. So that's a completely different environment. So we can't say for sure whether the UV is going to be bad because it kills the good stuff yet.
Great, thank you. We're getting close, but I want to wrap up with the thought and question that I have, that this is a really good example of literally science happening in real time, in front of our eye. You know what I mean? Here's what we know, here's what we don't know. It's also taking place both in the peer-reviewed literature and at the same time with a lot of public eye focused on what we know. So I'm curious, I would love to hear from both of you, as we've shifted through this virus and our understanding from where we started to where we are today, what are some good lessons about, the role of science as it evolves, and how do we talk about, what we know and what we don't know, when it's a very very sensitive, very pressure, very loaded, very, public health concern way. What has shifted in your understanding about the role of information coming out? Maybe I'll start with Shelley, and then John, you can close with your final thoughts.
Yeah, sure. There's a couple of things that have been really wonderful, is that my international community has really come together with interdisciplinary scientists to try to help to help support the science and the communication of science. We've been really frustrated that the WHO and CDC haven't been out in the forefront of providing the kinds of information that the world needs to understand transmission. And so that's why we wrote this letter, trying to get people to understand that there is aerosol transmission happening. And so what I appreciate is that the international science community has come together. What I'm also understanding, though, is that, I need to only speak about what my expertise is. I'm not an epidemiologist, I'm an engineer, and I can tell you a lot about ventilation filtration, but I'm gonna leave, I'm going to work with an epidemiologist, and I'm going to let them tell what they know about their expertise, and then working together in that way to really get the clear message out to the public has been a real struggle and really a push from us scientists. So it's taken a lot, I have to say.
Well, we could probably talk for quite a while about the question you raised, of course, Kristen, but a few comments. I mean, one is that it's surprisingly how little we knew about airborne transmission of viruses heading into this pandemic. I think second, the research community has responded quickly in a very interdisciplinary way. So you have, engineers, aerosol scientists, and others speaking to each other cross-disciplinary in a fashion that just was not happening before, this being driven by the urgency of the pandemic. Third, this has led to just an explosion of papers, some in the peer-reviewed literature and some in this preprint realm, where there's literally thousands on airborne transmission at this point, some quite important, and there are a few really seminal papers that have come along. I think it was in this context that the idea of the workshop was an important one, that we have this convening of researchers under the umbrella of the national academies to present the science, to discuss the science, and to distill down through the workshop discussions what it is we know, and I think also importantly, what it is we don't know, and then how do we fill the gaps. This type of workshop could easily be repeated for other elements of the pandemic. And, perhaps in 4 or 5 months, we will need another workshop on airborne transmission because the science will have advanced. So I see this kind of workshop as really critical for moving from all the research done by this extraordinary global set of researchers to bring it together as the sort of the foundation for action. And that's where I see the National Academies as being the right vehicle for doing that.
Absolutely. Thank you both. Thank you to all of our audience today. I really appreciate it. We had a really engaged audience with lots of questions. This is a really timely topic. Hopefully we've been trying to make these episodes, John and I and our team have been thinking through how do we bring you timely topics at the same time of, you know what I mean, keeping things flowing. And I think this one was a really timely one. And speaking of timeliness, we're going to take a break for Labor Day, but September 14th, we're going to talk about vaccines and herd immunity again. And I feel like with half our topics, we could go back and explore them and do a kind of a refresh of where has our understanding shifted and what did we say then and where have we said now. So huge thank you to our speakers today. Thank you to all my museum colleagues and of course the School of Public Health for helping us put this together. We do written recaps and we have video recordings of all of our previous episodes. Just go to institute.dmns.org, follow us on our social media, sign up for our newsletter. That's how you kind of stay up to date of what we're doing with this series. So thank you everyone for tuning in today. Hope you have a great rest of your week and we'll see you back here on September 14th. Thank you, Shelley. Thank you, John.
Thank you. Bye.